patients off the breathing machine. So if we come up on 5, 6, 7 days and we haven't made any substantive progress in terms of getting him off the breathing machine, that's something I will explore with you guys. Okay? All right. So first things first, we're going to put him on some antibiotics. We'll leave that tube in place. The other thing that we have to be concerned about is his surgery was around 3 or 4 weeks ago.
Yeah, it was on the 3rd.
There's a part of the chest, it's kind of like a partition, it's called a mediastinum. It's just the middle part of the chest. Whenever you have one of your lungs taken out, that area is kind of unstable. It can shift. And so the further you're out from the surgery, the more stable that becomes when your body starts to form scar tissue. He's not quite right at the time frame. You know, another couple of weeks downstream and that area would be pretty stable. So that's another reason why we're kind of taking this in a graded fashion. Okay. Any questions?
Thank you.
Yes,
Yeah,
ma'am.
no, I have questions for sure. The whole, you were saying that he had a whole, would that have been, he's been having a really hard time breathing. Obviously, he has one lung now. Would that have been affecting that? Would that have been making it worse?
I don't know. Was he has a history of lung cancer? Any smoking history?
Yes.
The right lung is the larger of the two lungs, and he had the larger one taken out. And that's a big deal in anybody, much less somebody who smokes. It's kind of like a non-smoker has $100,000 in the bank, and a smoker has $10,000 in the bank. You have just smaller reserve to begin with, and so taking $1,000 from that guy with $100,000 is less of an effect than the guy with $10,000. And
Yeah.
the same thing happens when you have to take out an entire lung. And so I can imagine that he probably was had a pretty rocky post-op course and was probably fairly short of breath when he went home.
Yes.
Fair.
Yes, yes.
And the first time he did so good with the first one, when they just took out the top, I mean, he was just riding his butt. I mean, it was kind of amazing.
Yeah,
So this, I think,
yeah.
kind of was a little, yeah.
That's a different beast, though. You're talking about taking out one lobe as opposed to an entire lung. And so whenever we are contemplating taking out a whole lung, I go over patients with a very fine-tooth comb before I make that decision, because quality of life becomes an issue. Some of these patients, and I've seen it, they look like a goldfish that you've taken out of water. They have horrible trouble breathing. Now, sometimes, and in some cases, the patients will slowly show some signs of improvement. So I doubt that he had the hole to begin with, but all of the ingredients were there for this hole to develop.
And do y'all repair the whole, like, what happens there?
At this point, no. And the reason is that he has a pretty, it's clearly infected.
Yeah.
And if I go in and try to repair it, number one, it probably is going to fall right back apart. Number two, at this stage, it is going to be hard to determine what is air passageway, what is his pulmonary artery, what's his pulmonary vein. I might go to put a stitch in there and put it right into the artery because I can't tell one from the other. It's all going to look like dog food in there.
Does it ever get repaired, or it could stay that way?
If this had happened like before he left the hospital, like if this event had happened while he was in the hospital where things were relatively fresh, then yes, you can go back in and say, aha, that's where the defect is. You can try to repair it at that point. But this far out, I would not recommend trying to go in and repairing it. Yeah. And that's just, that's kind of an approach that's been borne out over several decades of managing patients with this particular problem. And I've seen it firsthand as well. Patients who, yes, they have a bronchial stump breakdown immediately after surgery, you can certainly go in and things are more obvious and you can go in and repair it. Even then, you're not guaranteed that the repair is going to hold up. But someone who's had previous radiation, granted radiation was several years ago, the previous radiation, previous surgery on that side, and it's the right side of the operation, and sounds like it was a very difficult surgery. Sometimes with some of these difficult surgeries, the blood pressure can be kind of up and down, and if it's on the lower end of things, the blood supply to that area is not as good as it should be, and that's going to promote breakdown. And Was he ever on any steroids, prednisone, or anything like that?
A couple of times, and I mean, not like long term.
Was he on it after the surgery?
No.
Okay, good.
They never gave him that.
Perfect.
The only thing they said they were giving it was some kind of breathing,
Yes, oh yeah, they had to do that.
but other than that, not any kind of. He was on heavy duty antibiotics.
Yes, ma'am.
Now, one can live with this hole that he has.
Oh yeah. And again, this hole is, there's a bronchial stump fistula, that's what he has. And there's a bronchial stump blowout where the whole staple line, or whatever you use to close it, everything just falls apart. That, unless it is recognized and treated fairly quickly, is pretty much incompatible with life. He clearly does not have that. I know that just from what I have seen, I know that from the report that I got from Dr. Thompson, and also from what I've seen in my evaluation of him a few moments ago. If that were the case, we would not be able to ventilate him. We would not be able to provide airflow into his respiratory tract.
Okay.
He would be extremely unstable. So that there's absolutely zero evidence of that. I suspect he has a very small area that has opened up, and sometimes patients are very lucky and they will spontaneously close, like in very short order. But more often than not, it's going to take a long process for this to kind of resolve. Now, one thing we probably will have to do, and I would strongly encourage you guys to consider it, is has he ever had any surgery in his belly?
He had appendix removed as a teenager.
Oh, perfect. I'm going to strongly suggest that you put a feeding tube in, okay? The feeding tube is not permanent. This is a tube that we go in through the mouth with a scope, and we stick the scope down. It's just like getting an upper endoscopy, and this tube comes out right below the left rib cage. The reason is that we do not want him not getting adequate nutritional support.
He's not eating.
It's not going to heal.
He's not eating.
He's lost 22 pounds in 3 weeks.
Yeah, and that may be part of the problem, is that you have to have protein, carbohydrate, and fat in order for your tissues to heal. If your tissues don't, you got to have nutrition in order for that. May be part of what's going on here, quite
He
frankly.
could not eat. His mouth would burn, everything, he just could not eat.
Yeah, that may have.
He wanted to, he could.
That may have led to this, quite frankly. That very well. There are two things that are preventable that could have led to this. One is steroids, and you said he was not on prednisone. The other is poor nutritional support. You have to have tissues, proper nutrition in order for your tissues to heal. And if you're telling me he lost,
No, he's even getting
atrophy.
atrophy. Shedding her leg like
His legs used to be beautiful. They all atrophied. In 3 weeks, he looks like he's 30 years older than he is.
I'm going to strongly encourage you guys, and we can potentially do that on Monday or Tuesday when we take him to the ward. It takes 15 minutes to do.
Yeah, my daughter had one.
Yeah, I mean, he does need nutrition. He hasn't.
We'll do that then. Okay. One of our team members will have you provide you with a consent, and the consent will have on it a PEG, and that's the name of the feeding tube. It's a percutaneous endoscopic gastrostomy tube. And again, we go in through the mouth with a scope, and we snake the scope down into the abdomen, into the stomach.
Okay.
And we can actually kind of shine a light and visualize exactly where the tube should go in, and we pass the tube.
Okay.
On very rare occasion, and this usually is in someone who's had multiple prior surgeries in their belly, they have a ton of scar tissue and the anatomy is distorted. On rare occasion, we can't do it that way, and we have to do an open G-tube. But if he's only had his appendix removed, the appendix is way down here, that should not be a major
That
problem.
was the only stomach thing here.
Okay, and the other part of the procedure is called a VATS, and that just stands for Video Assisted Thoracoscopic Surgery. And that will involve making a couple of 2 or 3 incisions like this over on the side of the chest. I put a scope inside of the chest, look around, and then I will irrigate the chest cavity. Now, there is a slight chance, depending on what I see, I may have to open the old, at least part of the old thoracotomy, the big incision that was made, and really irrigate that area. But that's something I want to hold off on at this point. Okay? And we'll get all of that done, again, either Monday or Tuesday of next week, and that'll give us some time for that anticoagulant medication to subside. Any other questions?
Thank you for taking care of him.
Sure, that's what we're here for.